Hello all, good afternoon. I'm Dr. Pranitha. Today we will have a discussion on hypoglycemia in newborn. This will be a case-based discussion. So we'll start with the first case. It's a 5-hour-old male baby born at term gestation, weighing 1.7 kilos. Born to a multigravida mother who's a known case of PIH, and she is on labetalol. So mother was given intravenous fluids during labor due to maternal exhaustion. What are all the risk factors for hypoglycemia in this baby? So some of our DNPs and fellows are also in this session.
Preterm, short for gestational age.
Yeah. Yes, very good. So what else? Are there any other risk factors? Apart from prematurity, small for gestational age. So labetalol is also a risk factor for hypoglycemia in babies, and IV fluids for mother given during the labor is also a risk factor. So let us discuss about the risk factors for hypoglycemia. Maternal risk factors being intrapartum dextrose infusion, maternal PIH, drugs given to mother like terbutaline, beta blockers like labetalol, oral hypoglycemic drugs to mother or insulin to mother, and maternal gestational diabetes or diabetes mellitus. And the fetal risk factors, the most common risk factors being premature babies, IUGR babies, large for gestational age babies, SGA babies, and sick babies, like especially babies who are asphyxiated, requiring resuscitation at birth, babies with sepsis, hypothermia, and babies with syndromic features, which we'll discuss a little later. So what are the clinical features of hypoglycemia in a newborn? So there are neuroglycopenic symptoms and there are autonomic symptoms. The autonomic symptoms being baby with sweating, pallor, tachycardia, tachypnea, tremors, jitteriness. And the neuroglycopenic symptoms are hypotonia, coma, seizures, lethargy, weak suck, and abnormal cry. Now let's go to the second case where a 15-day-old infant is brought with complaints of lethargy, irritability, loose stools, fever. On examination, we have seen that the baby hasn't yet reached the birth weight. Baby is febrile with prolonged jaundice. And on examination, there is hepatomegaly. So we have sent up some basic workup because there is prolonged jaundice. And the CUE and cultures have revealed that baby has E. coli sepsis. So which of the following test clinches the diagnosis? So first of all, what is the case and how can we diagnose this?
Related to IEM.
Okay.
This is galactosemia, ma'am. Prolonged hypoglycemia, prolonged jaundice, and E. coli sepsis. And this is because of decreased galactose 1-phosphate uridyl transferase in RBC.
Yes, very good, Shruti. So this is the classic triad of galactosemia, E. coli sepsis, prolonged jaundice, cataract, failure to thrive. Cataract may not be seen initially. And so it is basically, we can diagnose it clinically also. And laboratory-wise, the bedside test is what we do is, what is a bedside test?
Urine for non-glucose reducing substance.
Yeah, very good. So the clinical features of galactosemia being, there can be developmental delay, especially if the feeds are being continued. Babies have cataract which develop little later in life. Prolonged jaundice is the usual manifestation. So in any baby with prolonged jaundice, we need to rule out galactosemia because it is a treatable condition. There is hepatomegaly. There can be kidney damage, especially if the baby is being given the normal milk, lactose milk. So in the second picture, we see a baby who looks quite sick. So this baby has purpura fulminans. So this is also a case of galactosemia. Baby also has a huge hepatosplenomegaly. And because of the severe liver disease, there is protein C deficiency, which is leading to purpura fulminans in this baby. So like we discussed the clinical features, there is cholestasis is predominant. The liver enzymes can be 10 times the normal. And the investigation's bedside one is urine for reducing substances, which will be positive. And once the reducing substances are positive, we usually next do the glucose sticks test. So if it is negative, it clinches the diagnosis of galactosemia. And then we can also send the enzyme levels of GALT and glucokinase levels. So management is being given the lactose-free formula. So this signifies the importance of clinical examination because a lot of galactosemia cases can still be missed if we do not examine the baby properly. So first, in any case of hypoglycemia, the first main causes in an NICU are babies with IUGR, SGA, and IDM babies. Babies who are hypothermic can also have hypoglycemia because of increased energy requirement. Babies with plethora, that is polycythemia, can also have galactosemia. Then we need to see for clinical features of sepsis, if there is any irritability, lethargy, core peripheral temperature difference, shock, respiratory distress, altered consciousness. Then see for IEMs, is there any hypoglycemia, low sugars, pigmentation, axillary and genital pigmentation, ambiguous genitalia, shock. See for cataract, jaundice, UTI to rule out galactosemia. The rest of the things I will discuss later. So now this is another case of a newborn with hypoglycemia. So there are few pictures. What are the findings in this picture? And it is basically a spot diagnosis. So can any of you tell what is the diagnosis? So you can describe the findings.
First image shows an omphalocele.
Yeah.
The third image has auricular pits,
Yes,
post-auricular pits.
yeah. So the second image is showing transverse ear creases. And the baby is also looking a little big, macrosomic baby.
Macrosomic.
Yeah, so what is this diagnosis?
Beckwith-Wiedemann.
Very good. So this is a spot diagnosis of Beckwith-Wiedemann syndrome. So if any baby is with macrosomy and hypoglycemia, we need to rule out Beckwith-Wiedemann syndrome. So here also we can see some babies with Beckwith-Wiedemann syndrome. They usually have midline defects. They might be born premature too, but some babies are usually macrosomic, most of the babies. They have mostly midline problems like macroglossia, umbilical hernias, gastroschisis, omphalocele, undescended testes. And in the second picture, you can see macroglossia. So these babies are born premature. It's basically an imprinting disorder. They have hypoglycemia at birth, due to which they can have seizures and may also develop developmental delays later. And the faces, they have this transverse ear creases, which are quite pathognomic, and posterior auricular pits. Along with this, they can also have gastroschisis and omphalocele, which will require surgery in the neonatal life. And some of them are also more prone to embryonal tumors. And that is the reason we need to keep screening them from time to time, at least every 4 monthly, for hepatic tumors and Wilms tumor. And we also screen their AFP levels. But in the neonatal life, we can see for any high insulin levels and KCN mutations and ABCC8 mutations. Management is for drugs for treatment of hypoglycemia, and refractory cases might require partial pancreatectomy. Along with that, they'll also require management for seizures, developmental delay, management for tumors, and some of them might also require nephrectomy. So let's discuss about the pathway of insulin. So the glucose usually enters the cell via the GLUT2 transporter, After entering into the cell, the glucokinase releases ATP, and this causes the closure of potassium ATP channel. So this potassium ATP channel has two subunits, the KCN1, which one of the first part is regulated by the KCN gene, and the second part is regulated by the ABCC8 gene. So these are the two main mutations which cause hypoglycemias in babies. And because of the closure of potassium channel, there is increase of potassium levels inside the cell, which causes depolarization of cell, release of calcium. The calcium causes release of insulin, and that is the main mechanism of insulin release. Okay, now let's go to the next case. So this is a baby who has come at 5-month-old age. The baby has developmental delay. He's not able to hold his neck. So please describe the clinical features, and it's also a spot diagnosis. So some of them are like pointed by arrows. So Rashikar, Shruti.
Macroglossia is present.
Yeah.
Then is that a skull bossing?
Actually, they're pointing to the widened AF. So macroglossia, widened AF. Facial features look a little bit coarse.
Coarse faces.
Yeah. And then there is some periorbital puffiness. There is some hypotonia. I'm not sure if it is very apparent to you all, but the child is in a little bit of frog-like kind of posture. There is some abdominal distension. So what is the diagnosis?
The storage disorder. Maybe hunters, hurlers.
Yeah. So that is also one of the differential for coarse faces. But the more common thing, if it is not screened at birth, child with mottling, prolonged jaundice, widened AF, developmental delay, coarse facial features, hoarse cry.
1 year.
Okay, so this is hypothyroidism, congenital hypothyroidism.
Okay.
So thyroid scintigraphy scan was performed for this baby, and it revealed the following thing. So what is this? So this is showing lingual
thyroid.
Yeah. So like we discussed, congenital hypothyroidism needs to be screened at birth because the clinical features may not be apparent. Like in this child who has presented at 5 months, and we have crossed the limit. Usually it should be diagnosed within the first 1 month, and treatment should be started within the first 1 month, so that the child doesn't have developmental delays. So the usual clinical features, again, in any prolonged jaundice, we need to screen for thyroid if it is not already done. C for widened AF, hypotonia, frog-like posture, large tongue, periorbital puffiness, abdominal distension, mottling, temperature fluctuations, umbilical hernia. These are all the clinical features. So the most common causes for congenital hypothyroidism being agenesis is the most common cause, followed by dyshomogenesis and ectopic thyroid. And the investigations done are thyroid profile, ultrasound neck, scintigraphy scan. And we usually start on levothyroxine, which is to be given at the early in the morning. Since we cannot give it directly on empty stomach to babies, we will mix it either with a little bit of milk, and the dose is 10 to 15 microgram per kg per day. So let's go to the next question, which is a baby has presented with hypoglycemia and the labs revealed lactic acidosis, dyslipidemia with elevated triglycerides, and hyperuricemia. These are all clinical features of hypoglycemia, increased lactate, increased triglycerides, increased uric acids.
I think this is von Goetz.
Yeah, correct. So this is glycogen storage disorder. That is type 1 usually presents in the neonatal life. The rest of the things usually do not present in the neonatal life. Von Goetz disease. So this again can be a clinical diagnosis. The babies usually have doll-like faces, and they can have huge abdominal distension because of the hepatosplenomegaly. And they have, growing up, they'll tend to have short stature, developmental delays, hepatosplenomegaly, hypoglycemias, especially with prolonged fasting. So hypoglycemia can prone them to seizures, intellectual disabilities. Because of the accumulation of glycogen, there is kidney enlargement and liver enlargement. And a characteristic feature is doll-like faces. So type 1 presents in the neonatal life. They will have hypoglycemia and fasting for a very short duration, 2 to 2.5 hours. So usually investigations we do is glucagon stimulation test can be given 2 to 4 hours after carb meal. So this increases lactate, but it does not increase glucose. And the diagnostic test is seeing the enzyme levels, glucose 6-phosphatase levels in the leukocytes and fibroblasts. And again, genetic study. And the management is by giving IV or NG feeds at night, feeding with slowly absorbed carbohydrates, and something which absorbs slowly, such as cornstarch, can be used growing up. The next one, we have a small for gestational age baby. Baby is brought with complaints of seizures, and glucose test revealed low sugars. What do you suspect? What are the findings and what do you suspect? So there are midline defects. Cleft lip is apparent, cleft lip, cleft palate, and then there is micropenis. So midline defects in an SGA baby with hypoglycemia, we should always rule out central causes, that is panhypopituitarism. So in any such baby, we usually do screen for all the hormones. We need to do the ACTH levels, the growth hormones levels, FSH, LH, serum electrolytes, serum and urine osmolality to rule out diabetes insipidus, prolactin levels. And the most important thing to remember about management is, in any case of panhypopituitarism with ACTH deficiency, always replace cortisol first, and then we need to replace the thyroxine to prevent the Addisonian crisis. So now this baby has hypoglycemia. We are increasing GAR. First, we started with 6. We are like increased to the maximum of 12. Baby is currently only 10 days old and is still requiring very high GAR. So the NICU team decides to start a drug at this juncture. And what is a serious side effect you need to be cautious of? What is the drug and what is the serious side effect you need to be cautious of? Yes, anyone? So this is a common thing.
Is that hydrocortisone
Yeah, we can start hydrocortisone.
or diazoxide?
Yeah, diazoxide. So what is the side effect of diazoxide?
I think it's hyperkalemia.
Okay. Fluid retention is the most common side effect. So that is the reason we also start them on chlorothiazide. So now let us discuss about the drugs for hypoglycemia. So hydrocortisone can be given, especially if there is some predisposing factor like sepsis. We usually start at 5 mg per kg per day in 2 divided doses. So it acts by reducing the peripheral glucose utilization, increases gluconeogenesis, and increases the effects of glucagon. The next drug is diazoxide, which is given especially in hyperinsulinemic hypoglycemia. So the dose is 5 to 20 mg per kg per day, which is given in 3 divided doses orally. So it binds to the SUR1 subunit and opens the potassium channels, potassium ATP channels. That is the most important action. And the side effects being fluid retention, which can be prevented by following volume restriction to maybe 120 ml per kg per day, and also by giving chlorothiazide along with the diazoxide. And another serious side effect is hypertrichosis, which is of more cosmetic significance. The other drugs which can be used but not very routinely used are octreotide. So octreotide inhibits insulin secretion by binding to somatostatin receptors and inducing hyperpolarization of beta cells. And it also causes direct inhibition of voltage-dependent calcium channels. The side effects being anorexia, nausea, abdominal pain, but more commonly seen is diarrhea and tachyphylaxis to the drug. So glucagon can also be used. It increases the glycogenolysis and it increases gluconeogenesis. So it causes nausea, vomiting, and paradoxical insulin secretion at high dose. So this completes my presentation. Thank you very much everyone for participating, especially Dr. Rashika, Dr. Shruti. Okay, so we'll end the presentation.